Good morning to all, and thank you for joining our presentation on mass casualty incident preparedness. My name is Kevin Riley, and I'm with the Emergency Management Department at Stony Brook University Hospital. I'm also the Regional Training Coordinator for the Metropolitan Area Regional Office. In this capacity, I administer the Health and Human Sciences Hospital Preparedness Program, and I do this in collaboration with three other regional training centers across the state of New York. Today's webinar is the first in a new monthly webinar series created by the training centers, and this initiative is designed to enhance the readiness of hospitals and EMS by providing the insight of various subject matter experts. We're going to focus our discussion today on enhancing medical surge capabilities by examining the amazing response to the Boston Marathon bombing, which took place on April 15, 2013. Just a couple of administrative notes as we get started. We like to make sure everyone enters the session, the attendees that is, with their actual full name, first name, last name, so we can properly take attendance. And the participants can use the participant button at the bottom of the screen to verify that we have your full name. Attendees should all be placed on mute with cameras off, and we're going to keep it that way for now. As far as communication purposes go, we're going to use the chat button located at the bottom of your screen to communicate with panelists and attendees regarding any logistical or content questions we have throughout the program. Please monitor the chat for messages from the host. And we're going to use the raise your hand function during the question and answer period, and we'll unmute you if you have a question at that point. You'll see on the bottom of the screen that we have a way for our panelists to get their certificates. I'm just going to leave a few seconds so people can read that over. And please note that also at the end of the presentation, I'm going to show that certificate information again, just so people have it before we close out the session. So on a personal note, I just have to say what a distinct privilege it is to associate with our esteemed panelists today and with each and every one of you in the audience. We are very fortunate to have with us 6 responders who really rose to the occasion in the wake of the attack. They represent a broad spectrum of disciplines who were directly involved with saving lives that day. I think by all objective standards, our panelists are heroes, one and all. Since we're following the continuum of care in this presentation, I'd like to do the introductions of our panelists in the order in which the questions are going to be asked. So let me start by introducing Mr. John Gill, Superintendent-in-Chief of Boston EMS. John is a paramedic who triaged and treated victims at the scene of the second blast site. We also have Dr. Sophia Dyer, Medical Director for Boston EMS and an emergency department physician at Boston Medical Center. Dr. Dyer was managing the medical response in the Alpha tent near the finish line during the marathon. Also from Boston EMS, we have Ms. Erin Serino, who is the Deputy Chief of Staff. Erin that day was in charge of patient tracking and managing critical medical intelligence at the finish line. Also joining us is Ms. Meg Femino, Vice President for Emergency Management at Beth Israel Lahey Health. On that day, Meg was the emergency manager at Beth Israel Deaconess Medical Center, just 2 miles from the scene. Our 5th panelist is Dr. Eric Goralnik, an emergency department physician and medical director of the emergency preparedness at Brigham and Women's Hospital. Dr. Goralnik was on Boylston Street when the blasts went off, but very soon after, he had to relocate, of course, to his emergency department where his services were most needed. I also have to thank Dr. Goralnik for all the help he did in helping me put this together. He took an onslaught of emails from me and responded very nicely in helping me put this together. So I appreciate that very much. Our sixth panelist is Barbara Tutulio, who is an RN and who is the Senior Clinical Operations Liaison for Perioperative Services at Beth Israel Deaconess Medical Center. On the day of the bombings, Barbara was in the thick of it, working on the other end of the continuum in the operating rooms. So welcome again to the panel, and thank you very much for sharing your experiences with us today. We have about 90 minutes to regale our audience, so we're going to focus what precious time we have on the things that mattered most to all of you on that day. As most of you know, 2 improvised explosive devices were detonated in rapid succession within yards of the marathon's finish line. These 2 bombs, which were planted among the many spectators on Boylston Street, near the center of the city, left 3 people dead and 264 people injured. Many of you are familiar with this iconic photograph taken just feet from the second blast site. But what may be less known is that 16 people suffered traumatic amputations and a total of 19 limbs were lost in the attack. 29 tourniquets in all were applied at the scene, and I think it's fair to say that aggressive hemorrhage control made all the difference that day. The one common denominator of all these types of intentional mass casualty incidents, regardless of the mode, the method, or the motive, is the dark cloud that they cast over society. So we're going to do our best today to uncover whatever silver linings exist in the response to these cowardly attacks. The bombing in particular was interesting in that 100% of the patients who were hospitalized survived the event. So it's a pretty stunning statistic when you consider the mechanism of the blast and the severity of the wounds. So our primary goal today is to extract a few pearls of wisdom from those who answered the call on Boylston Street and also from those who served in Boston's hospitals on that day. We're first going to examine the challenges at the crisis site and the initial sequence of the response, and then we're also going to work our way through the entire continuum of patient care from the blast site to the emergency departments and then into the operating rooms. Let's begin this journey on Boylston Street at approximately 2:49 p.m. that afternoon. Excuse me, and I'd like to start by asking Mr. Gill and Dr. Dyer to kind of walk us through the more tactical responses in the opening few minutes. The first bomb detonates in the crowd at the finish line. 13 seconds later, a second bomb detonates in front of the Forum restaurant, about 180 yards up the street. And I can't help but liken these 2 explosions to the 2 planes that flew into the World Trade Center on 9/11. Excuse me. The first explosion, like the first plane, is startling and confusing, but the second explosion, just like the second plane, makes it perfectly clear that an attack is underway. So my first question is to John. John, as a paramedic at the second blast site, you really had to rapidly assess the situation and set some pretty quick priorities. Can you tell us what your first thoughts were in the first few seconds and maybe describe the immediate life-saving interventions that took place? I guess we're talking about gaining access to the victims, primary triage, hemorrhage control, those sorts of things. So I'll turn it over to you and you can tell us what your experience was.
Good morning. My initial thought was that I should have taken the day off. After that, the real concern is there another device? We didn't know. There were 2. There were other suspicious packages found in the area. As far as the priorities, very early on, the hospitals were notified of a potential mass casualty incident. That's critical so that they can start their internal disaster plan. As far as access to the patients, barricades were up on both sides of the street. They had to be moved into the street so that we could get to the patients, making Boylston Street narrower than it already was. Tourniquets were being applied by firefighters, police officers, civilians. That was critical, I think, in the rate of saves that we had.
Interesting. About do you recall about how many victims were at the second blast site? Obviously, a large number. Maybe you don't have that number readily at hand.
I'm going to, off the top of my head, I'm going to say we had roughly 15 to 20 people there, varying degrees of injury.
Gotcha. Okay. Dr. Dyer, you were the medical supervisor in the Alpha Medical tent at the finish line. Now, I understand that several of the critical patients were triaged and loaded onto ambulances right at the blast sites. But I think if I have my data correct, most of the victims were taken to the Alpha tent casualty collection point, where I'm assuming secondary triage took place, and the point from which most patients were then loaded onto ambulances. Can you describe for us the initial thoughts and actions of you and your team at the Alpha tent as you suddenly had to transition from treating sports injuries to treating scores of traumatic casualties?
Yeah, thanks for that question. So at my role as one of the co-medical directors of the marathon, I spend most of my time at the Alpha Medical tent. At the exact time that the bombs went off, I actually was standing with our crew actually at the finish line. So then responded to the initial blast site. And we have exercised with the medical folks in the Alpha Medical tent, never particularly a bomb, but just a process that should anything go wrong in the medical tent, the volunteers from the BAA are fabulous about working in conjunction, but taking the lead at that point from our uniformed EMS personnel. And that's what happened as they quickly triaged over a lot of patients and then quickly moved the command for all those activities in terms of loading to our EMS professionals. The medical volunteers then did a lot of very rapid discharging. And in fact, some patients discharged themselves as well, who were there for hydration and other sorts of things. But as you mentioned, a lot of the primary focus on, and as John mentioned, on hemorrhage control and basic trauma assessment skills.
How was the medical tent staffed and equipped? Just in general terms? Am I right in thinking there was 80 or 100 people there just preparing for the marathon injuries? And did that staffing change once you?
Yeah, so the medical tent is typically staffed with a fabulous amount of nurses, their physicians, their physical therapists, and there's a tremendous support staff as well for that medical tent. EMS has a separate section where we bring all our equipment along with us so that it's readily accessible for any event that could happen in a marathon. And in this situation, it was a lot of trauma supplies as well.
Mm-hmm.
And the medical staff was great at taking direction from the uniform EMS providers there and helping share the load.
I understand the Alpha tent was just beyond the finish line at Copley Square. About how many feet away was that? Was it close enough to feel the concussion of the blast for those in the tent?
Yeah, so again, I was at the finish line at the blast. I'd have to ask people who were at directly at the tent. However, what I do know is that it was quite a unique sound that we heard. And my memory is that a large contingent of military, they were doing the walk that they do from the start of the marathon. They walk in their boots and then their uniforms and their 50-pound packs. This is a tradition as part of the Boston Marathon.
Well, who wouldn't want to do that?
Right, exactly. And all those National Guard and servicemen immediately jumped up from the podiatry section and rushed to the finish line. And they were, as John was mentioning, there were barriers up. My legs weren't long enough to stride over the barriers. I tried. And they were there in, it seemed like a split second, and started tearing the barriers down so that all of the responders who were there could begin and start treating patients.
Well, thank you for sharing that. Are there any particular challenges that came to mind at your experience where you were? Well, obviously a very challenging day, but
Exactly.
I wonder if there's one that stands out the most.
There were so many great actions that people took and challenges. I do think though, one thing that does stand in mind is really the fabulous response that our EMS providers were in terms of improvising. They had a point where they needed to move a patient and couldn't find a backboard quickly, so they went into a local retail store and pulled out a shelf and helped use that as a means of conveyance very briefly.
You got to do what you got to do.
Yeah, you got to do what you got to do.
Okay, very good. So our next question is for Erin Serino, and it kind of transitions us from the tactical response to the more operational phase. Erin, if I understand correctly, you were the leader of the patient tracking team at the finish line, a team that also provided situational awareness to the Medical Intelligence Center, who then coordinated with numerous other healthcare and governmental stakeholders. Can you tell us what that entailed and how difficult it was maybe to manage information early on, given the initial chaos and perhaps your proximity to the first blast site?
Certainly. So for the day of the marathon, I was assigned to the first medical tent at the finish line. My responsibilities, as you had mentioned, included overseeing the patient tracking operations for the entire Boston Marathon, to include the course and the finish line medical tents. And in doing so, provide situational awareness updates to Boston EMS officials, as well as race officials and the Medical Intelligence Center. So a little background on the Medical Intelligence Center. It's our multi-agency coordination center that is designed to support our health and medical community here in Boston during planned and no notice incidents. So the objectives of the center is to provide situational awareness, to provide resource coordination, as well as human service coordinations during incidents following them. So at the time that the blast went off, my first reaction, the blast went off at 2:49. My first reaction was to radio the MIC at 2:50, notifying them of an explosion. Didn't know what it was, just knew there was an explosion, relayed the information, and within shortly thereafter, we received additional information in the medical tent that we were to expect injured patients. So within a matter of minutes, the MIC was then able to provide a notification to the hospital emergency managers. And this notification, coupled with the notification from Boston EMS, really triggered the overall healthcare system response to the incident at hand. I think some of the challenges that followed that initial notification and mobilization dealt with interruptions and failures in our communication system. So there was an outage with regard to cell phones. So we really had to rely on our existing radio networks to communicate back and forth for the situational updates. Secondarily, as John alluded to, was the concerns of additional devices, and our reliance there was on our law enforcement partners to update us on those situations. And then lastly, in the hours following the bombings, was really dealing with information that was shared via social media. And the MIG monitored social media channels to either validate or discredit reports and find reports from credible resources.
You mentioned the security aspect. That had to be very difficult for anyone who was on scene because there's a lot of unknowns, and security has to come first and foremost, because you don't know what's going to happen in the next few seconds, or the extent of the attack, which was not known for quite some time. And you also mentioned hospital notifications. It sounded like the initial notification systems, or rather the initial notifications that went out, provided pretty effective information. They came in very handy for the hospitals. So, okay, very good. Thank you for your input there. Our next question is for Meg Femino, and it moves us into the hospital settings. So, Meg, from your position in your hospital, can you describe for us how the external alerts and the external notifications you were receiving were then, synthesized into actionable intelligence for your hospital command center, and actionable intelligence to set up a commensurate HICS activation, and then maybe you can touch upon the composition of your hospital's incident management team.
Sure. I think what I'll do before I get into that is give a little background and set the stage of what's happened before this at the hospital.
Sure,
because
please
that
do.
is really important piece of this. So this happened the day of the Boston Marathon, which happens always the third Monday in April, and it's on Patriots Day in the state of Massachusetts. And I call it a quasi holiday because it's a holiday for the hospitals, but it's not a July 4th Memorial Day holiday where a lot of people are out of town. Some hospitals run ORs, some don't, or run a limited schedule of ORs on this holiday. And the other piece is, in the city of Boston, we've been working together for really since, I think very robustly since 2004, when we hosted the Democratic National Convention, which was the first national special security event post 9/11 in the country. So we had created a lot of systems, a lot of pre-planning, and the Boston Marathon is considered a planned mass casualty for all of the hospitals in the city of Boston. We plan annually with our citywide partners months before the marathon ever happens. We create an internal hospital plan that involves multiple departments planning for mass casualty. And we talk usually, the big thing is about weather extremes. Is it going to be too hot? Is it going to be too cold? In 2012 was the hottest marathon on record. And we had an MCI that year too, with over 50 patients in the ED from heat exposure. But in 2013, it was perfect running weather. The temps were low in the 60s. But it is a planned mass casualty. And the important piece for that is and I'm going to speak for Beth Israel Deaconess Medical Center, but I'm pretty sure that most of what happened there happened at all the hospitals across the city of Boston. We do have a little bit of a unique story in that this event for us wasn't just the victims. We also received both of the suspects, and we were caring for victims and suspects simultaneously at BI for 2 weeks post the bombing. But we have an emergency manager that is on site during any of the 3 planned mass casualties, which are First Night Boston, the Boston Marathon, and July 4th, because we know of the influx of people into the city. BI is an urban academic medical center. We have about 3 million square feet of space. We have about 700 licensed beds, 75 critical care adult beds, 40 neonatal intensive care unit beds. Our EDC is about 60,000 a year. There's about 9,000 employees, and an important takeaway for us is about 40% of our employees arrive to the hospital every day using public transportation. And that came in to be a really important factor on the day of the lockdown, which I will get to. In I have to say, pre the bombing, we have a very robust incident management team at the hospital with a lot of very experienced people because we're big on drilling. We have a very low threshold to activate our EOP, or Emergency Operations Plan. And in 2013, the hospital, for example, responded to about 31 events across infrastructure interruptions, mass casualties, security events, hazmat, and code help. And it's a very stable incident management team. And the incident commander, the person that's taking the incident command role, is alerted of the planned mass casualty and is on standby and very available that day. So there's a lot of multidiscipline interagency planning that goes into the marathon. There's a lot of information sharing that happens pre and during and post the marathon across hospitals, EMS, and Erin mentioned the Medical Intelligence Center, which is very important. They provide surveillance and monitoring for us. And we have EM on site, which made a big difference for the day of the bombing. Our impact to our hospitals was there was about 280 patients that were treated at 27 hospitals. Really, most of them were in the city of Boston, but some people with hearing issues may have gone home and seen at a hospital there. BI saw 24 patients. We had 10 reds, 6 yellows, and 8 greens that came in. And the first patient arrived to our doors about 11 minutes post-blast. And we received 10 red patients within 37 minutes. If you had ever asked me the day before if we could do that, I would say no, probably not. And a total of 14 of our patients went through the OR that night at BID. There was an extraordinary outcome, and in that anybody who was sent to the hospital survived their injuries. So that was an incredible outcome. As far as our coordination tactics and our communication, as Erin mentioned, the hospitals were notified within minutes. And I remember the first piece of communication that came was there was an explosion at the finish line, could have been manhole covers exploding, because that has happened in the city of Boston multiple times, believe it or not. But it's literally a few seconds later, I got another one about a second explosion. That immediately tipped the hospital into this could be a potentially an intentional event, and we're going to treat it so until we know otherwise. So we also heard over the CMed radio, you know, I'd never heard a message like that. You could hear the high threat environment in the voice of the person who gave the message that prepare all hospitals for incoming MCIs. Most of these are critical. So at that point, we set off our code triage maxi alert, which will alert everybody on the incident management team. And don't forget there's social media that we're monitoring messages on, but they're not confirmed messages. So we're very careful with social media. But we're making some assumptions right away that this could be potentially intentional. We are also going to upgrade our security practices at that point. And we know because it's explosions that we're going to prepare for surgical trauma. So everybody's alerted. People are watching the marathon on TV, which is another important point. Employees are seeing this on TV and thinking, and they're deploying to the hospital, just self-deploying themselves from what they're seeing, even though they weren't alerted. So our coordination tactics really, once that code triage went out, we're waiting for incident command. Our incident command center was stood up within 10 minutes because we were on site. The ED immediately pushed the code help button, which is a way to decompress the ED and send patients to the floor so we can, I call it the purge to surge, so that we can get people in and have room in the ED. Immediately, the trauma bays were retooled from cardiac chairs to stretchers. Triage was set up outside in the ambulance bay. We made some critical decisions about decon or no decon, but we sent the TED up until we had enough time to make the decision that we were going to bring people in and scan them with the Geiger counter before they went in, but then let them come in. We set up a call center, was established in the conference room because we know from previous mass casualty experiences that finding families and finding people becomes a huge issue for the public. We restricted access immediately, made sure that nobody was coming in unless they were a patient or an employee. Everybody who came in was patted down and searched and had to show a badge if they were an employee coming in. And they were also screened before they come in, because you don't know if the perpetrators are going to be in the mix of people, et cetera. And I'm sure Eric will talk more about that. We deployed nurses from the ICU down to the ED to help out with patients. We had floor nurses come down, and we practiced this many times before. If a code help is hit, the floor nurses come down, get the quick report, and then they transport the patient upstairs. We don't wait for transport. We don't do any of that. Things are really abbreviated if it's a code help. The ED implemented small zoning, which that all the teams were told to stay in their rooms, and they had doctors, the senior physicians were rotating outside those rooms, really for mental health of the responders. Victims, we set up different alternate care sites, and I'll talk about those. Barbara's going to talk about the prioritization of OR cases and how they went upstairs. And the other important thing that we did was reached out to New England Baptist Hospital, which is a orthopedic hospital that does not have an ED, so they don't receive victims typically. And we asked what their OR capabilities would be, and we were able to get 7 ORs, you know, with teams that night if we needed to send people up to the OR. So like I said, our operations center was set up within 8 to 10 minutes. We secured the West Campus. Then we also secured the East Campus, which is about a block away, but it is still part of our hospital. And sometimes people self-report into the East Campus when the ED is on the West Campus. So we secured both of those locations. You know, during the day, there was a lot going on with threats that were happening at different places at Lenox Hotel, UMass. We were getting continual communications from the MIC, which is the Medical Center, the Boston Regional Intelligence Center. DPH started sending messages out. So we had people that were simply just monitoring what is coming in. I was the deputy incident commander for the hospital and tapping us on the shoulder like, Meg, I think you need to hear this, because it got too much for us to all monitor all of the communications that were coming in. And Erin did speak to the fact that cell phones were jammed, so we went to texting. And also, we had to do a lot of communications internally for employees that were coming into the hospital about rerouting where they were going to go, that kind of thing. And, you know, during, in the early hours of this, the ED became very overcrowded with employees showing up wanting to help. You know, we had podiatrists come in, everybody's intent was really good, but we had realized that our labor pool plan was something we thought that we would initiate. Now we know it could be triggered because so many people are coming in, so we get them out of the ED, and we have a system now of who's going to manage that labor pool, so we get the people that we need to get in. We had a full incident command team there. There had to be 75 people in the command center, but it's a very well-rehearsed incident command team. And I can't tell you how many people that have roles in incident command said, you know, Meg, we all thank God for all the training that we've done, because everybody knew their role. They came in and they went to work and they got their job done. Nobody was looking at job action sheets. We were way past that and where that incident management team was. And we created what we call the swarm intelligence. And Eric, you'll probably mention that about how teams work together. You know each other's strengths and weaknesses, and there's not a lot of talking that goes on. We give briefings, but people know what they need to do, and they set up and work to the objectives. We opened our ambulance bay as a triage and a decon area before people went inside. We opened up our ED waiting room, became the urgent care area. Our ED observation area became an extension of our acute care ED, and our PACU holding area became our OR holding area, and the ED conference room became the call center where social workers were answering calls from people looking for family members. I want to just mention Friday, you know, Monday was the day of the bombing. We received 24 victims, caring for them that whole week. But on Friday, they locked the city of Boston down, and that communication started at about 5 a.m. We happened to be in because we had received the first suspect the night before, and he was dead on arrival, as everybody knows now. But there was really good communication, and I have to say the communication that happens is very well set up and processes are really well practiced. And I have to say, Erin, I don't know if you remember, but we were getting the suspect and the TV said they were going to the general. Erin calls me on my cell phone and says, Meg, you're getting him. I said, okay. But we have that network that had been so well established very far out that we had each other on speed dial. I know who to call for what question, that kind of thing. So Friday was really difficult to manage because they shut the MBTA out at 5 a.m. A lot of people that are coming in aren't looking at the TV, and 40% of our employees come in. So that created kind of a fog of war, to be honest with you, for about a half an hour until the incident management team said, you know what? This looks like a lot like a snowstorm. So we were able to transpose strategies that we use for snow into this, and it worked very well. And then Friday evening, we received the second suspect, and that whole piece was extreme law enforcement. We had a lot of issues, and I'll talk about that in our next segment up with staff that was caring for the perpetrator and staff caring for the victims, and kind of the issues that we had in there. But there was a tremendous amount of communication externally and internally through that whole 2-week event. Because we had a lot of media presence on site. You know, we had cameras looking into windows, looking for the suspect. There was a whole host of different issues and complexity that added to that response for us at Beth Israel. You know, but the big piece and takeaway is, you know, hospitals need to be prepared with incident management teams that know where they're going, know what their role is, and can fall into it very, very quickly. And also the establishment and the work that is done previously with all of our interagency partners and the network that we have and the drilling and the training that we do together as a collective group in the city of Boston. No, we're not in our silos at all. And I'll stop there.
Well, thank you for your amazing rundown of the response. I have to say that your command of the facts is both remarkable and incredible. It sounds like you place a great emphasis on prior planning and establishing those relationships ahead of time. It sounds like a lot of that was going on. And it also sounds like your hospital was very good at planning and sort of anticipating what might go wrong. You mentioned that when you plan for the marathon, you're also planning for a mass casualty incident. And I'm assuming you're not talking about jogging injuries when you think about that. You're going with a worst case scenario where perhaps there is an attack of some sort or
well, not just terrorism, we actually focus on all hazards. So like on July 4th, there's been porch collapses. There's all kinds of things that we prepare for. I do think the marathon bombing put a whole new twist on how we think about bleeding, hemorrhage control, tourniquets,
right.
From the lessons learned from that, but I'm sure Eric will address it.
And it sounds like the information you were getting was sufficient in terms of speed and quality and quantity to allow your hospital to swing at action for a worst case scenario.
We
right
turned
away.
very quickly. I think all of us did. We recognized that this is going to be big. We had no idea of the scale and scope, but when you hear explosions, you have to prepare for a lot of casualties.
Exactly. Thank you for that insight. We really do appreciate it. Our next question is for Dr. Goralnik. Doctor, can you describe for us how your emergency department activated, organized, and deployed its response teams, and what treatment process did the most critical patients undergo before being transferred to a surgical team?
Yeah, thanks so much for hosting us today, Kevin.
My pleasure.
I just want to acknowledge two things briefly. One is, we're I think all of us on the panel are honored to be present today and share with everyone our experience. But this was really a whole of community response has been drilled into us over the years, and everybody stepped up in a variety of different ways, well beyond the medical, public safety professional, and public community. So thanks to everyone for that. And the second piece is, I know we're focused today really on response, But that was really such that almost the smallest sliver of this whole experience as the superintendent, as Aaron and Sophia and Meg have relayed. The arc begins way before around preparedness and teaming. And then the longer arc is the recovery in many cases that continues today, will continue for some time. So focused on the immediate response for us, I think Meg hit many cases, their response at BI, which was similar, I believe, after multiple debriefings we had with across institutions. So I'll try to pinpoint, add on to some of the points without repeating some of those points. So, the immediate response was when patients first hit our doors. We initially received the call at 2:54, and that was that there were some explosions at the Marathon site. And at that point, that was received by our nurse in charge. And in our emergency department, we have 4 pods. Each pod is about 15 beds. This is our old emergency department. So there was immediate discussion with the attending physician, who was a veteran of multiple deployments overseas, including the Haiti earthquake, and our nurse in charge, who had worked for over 20 years in our department and had a great deal of experience managing crowding, which we quite frankly do on a routine basis. And so the intent there was that those two teamed with our emergency manager, who was a retired police chief and had worked at the Brigham for over a decade, and went through the initial MCI checklist, activating our teams. And once that occurred, patients started to arrive. The first patient arrived about 15:02, so about 12 minutes after the bombing. We have it on record at 15:08, but it was somewhere in that time frame. And those patients were triaged to different rooms. And triage was led by our former EMS director, who basically rapidly identified them. About 40% of the patients were tagged prior to, and they were re-triaged or resorted at that time frame. I think some of the key points I want to highlight about the response here are the secondary triage, which was really critical. Our secondary triage, we learned a lot on the fly, and that secondary triage was led by one of our trauma surgeons, and it involved emergency medicine, orthopedics, and anesthesia. And that team rounded throughout each of the pods to rapidly identify patients that that had life-threatening injuries, limb-threatening injuries, or needed a delayed procedure. And really that triage rubric was led, quite frankly, although our trauma surgeon led that effort, or orthopedic surgeon remembered when he rotated on a trauma service at UCLA. And there was, if you remember, in the early 2000s, there was an elderly individual that ran his vehicle through the pedestrian farmers market in Santa Monica. And at that time, there were multiple deaths and injuries from that. Well, Mike Weaver is his name, was the individual that was an intern on rotating there and experienced that. And he asked the trauma surgeon, once they got the call at that point, the farmer's market, what do you do? And he said, I pull out this card and I categorize individuals in those 3 categories and I go to work. And that's exactly what Mike did. I think he still carries around the piece of paper where he triaged those patients. And many of these stories of individuals like John Gates, who was our trauma surgery leader, reflected on the exercises he had been through, how one of the first exercises we did in 2010, when we first ignited a mass casualty alarm, he went directly to the operating room. And he acknowledged in the debrief, his job was to triage patients and actually stay out of the operating room so his peers can care for those patients in the OR. And that's exactly what he did that day. So I think we learned a lot from our collective experiences. Those were all positives. The key points and takeaways for us and learning opportunities just solely in the response were around patient tracking and identification. At the time, we had our own homegrown system with regard to patient tracking and an unidentified convention, naming convention that was a series of numbers. So what that led to is confusion between where patients were located, how they were registered. And of course, if you can't register someone, you can't have them in your tracking board, and then you can't do orders for them. So that led to some delays, caused some confusion around X-ray mix-up. Fortunately, we didn't have any lab mix-up or blood transfusion mix-ups. but there were a lot of near misses. And that was a universal experience, by the way, across each of the hospitals when we facilitated debrief in June of that year. The number one bottleneck was electronic order entry and patient tracking across every level 1 trauma center in Boston. The second piece, Meg referenced this, was labor pool organization, I think. We had a labor pool forming area that was external to the emergency department, but everybody shows up. They know that the action is happening in the ED, and people will show up and they want to help. And so we had to use our own staff to perform crowd control, which becomes a challenging issue. So labor pool organization was a key piece. And finally, everybody references sort of number 1, 2, 3 communications. The one thing I want to highlight is the social media piece. Many of our staff members heard about the event prior to the calls that we had from Boston EMS, simply because they saw it on Twitter. And there's a wonderful study that was done by Chris Casa and team John Brownstein at Boston Children's, where they looked at the fire hose, which is the Twitter feed from the experience. And you'll note that there's somewhere between 25 to 30 tweets that were sent prior to public safety agencies and news channels tweeting or providing that information. Of course, this is now 8 years old. Times have changed, but this is a great exemplar of the power of the public and the opportunity to engage the public, to be the true first responders. We heard about Stop the Bleed and providing pre-hospital hemorrhage control. There's the opportunity to be truth messengers around social media and getting that information out in a rapid fashion, in addition to other sort of layperson or upstander programs to try to, again, empower the public to be sort of the true first responders.
Right. Well, I'm very happy to hear you invoke the value of Stop the Bleed. It's a campaign I believe very much in. I think almost everybody does now. So you had the benefit of a lot of experienced people at the time of the incident, sounds like. And the labor pool you referred to, that was of additional staff members, hospital staff members coming in looking to help. Is that right? Or did it include people from outside the organization as well?
Yeah, so during the initial response, it was really hospital staff members that were showing up. We didn't have too many non-hospital staff members show up and volunteer, although we did get calls coming into our main lines about individuals that wanted to volunteer. And you could imagine the amount of individuals that show up and want to help. And it's wonderful, but it does become a real logistics challenge to redirect staff members so that we have enough space and people have are assigned to teams and roles to care for patients. So
Right.
It did cause some confusion.
Not always easy to manage. So you had some MCI checklists, which sounds like went pretty well, and it sounds like the triage process went pretty well too. So my hat's off to your emergency department, as well as all the emergency departments throughout the city. Thank you very much for that answer. Very enlightening. So our next question is for Barbara DiTullio. As a perioperative registered nurse, can you walk us through the process of having to quickly staff multiple operating rooms and the challenges you faced in triaging a large number of amputation candidates? I guess that was maybe the primary concern. That and hemorrhage control, of course.
It was. And thank you for having me. This is a really great forum. And definitely this day and event will live in the minds and hearts and memories of all of us in the city for many, many years to come. As Meg has mentioned, we had done quite a bit of work previous to the Boston Marathon around drilling and emergency management of mass casualty events. So at that time, I was the nursing director for the operating rooms at Beth Israel Deaconess Medical Center. And as such, I was on a first responder team, if you will. So I got a first round of pages. In other words, I was paged early on and immediately heard the news on the TV and literally got in my car and headed to the hospital. As Meg had shared, we have a hospital holiday on that Patriots Day. So as such, we only do emergency and urgent procedures, and they had just had their last patient leave the operating room. So all of our operating rooms were available and obviously not staffed because it was a holiday. We also had holiday staffing. So in the time that it took me to drive from my home into the hospital, I arrived to a scene where multiple staff members of every level were already at the hospital. They heard of the event, they knew what was going on. Many of them had been in the city. I think there was a Red Sox game that day also. So many had been at the marathon or been, preparing to go to the game. So immediately heard of the events and headed to the hospital. So we had a pool of not only surgeons, but anesthesiologists, nurses, surgical technologists, and many of our staff were staff that came to the trauma ORs. We have acute trauma ORs here at Beth Israel Deaconess. And then the East Campus, which Meg also mentioned, is our less acute, more ambulatory type procedures. But staff from both operating rooms showed up because they knew that they were going to be needed and needed to help. When I arrived at the hospital, there had been a charge nurse that was in place all day, taking care of the operating rooms. So we made a decision very early on as a leader, rather than step in and take over, it was more important for her to continue what she was doing. And as a leader, support the activities and remove barriers so that the work could go on. So what happened is when we identified somebody, and again, much of this work had been sort of drilled in previous events with Meg and her team. So there was somebody that was stationed in the operating room, somebody that was stationed in the emergency department, and relaying, we have a patient with this particular injury that is going to need this particular team. So we were able to not only receive that patient, but quickly identify those staff members who would be best suited to take care of that patient and deploy the team at the same time. So when I got to the operating room, there were already 2 patients in the OR and many more patients were on their way. We had many patients in the ED at that point. I think some of our initial challenges were, in addition to crowd management, was identification of patients. Nobody could be really sure that the belongings that we had actually belonged to the patient that we were working with. So that was one really difficult complication. I think the other thing that we didn't really know is we had no way of knowing whether the patients that we were dealing with were victims or maybe one of the perpetrators of what had gone on, because everybody at that point quickly realized that this was a planned event and it was, it was something we had to be mindful of. We, worked through some of those early surgeries and getting people in, and then quickly realized that we were going to need more instrumentation. So we arranged to have staff transport instrumentation and literally drills and saws and things like that from our other campus across the street to the West Campus, so that we would have them available for surgeries. One of our biggest challenges really was around specimen management. So we had every level of law enforcement. We had local law enforcement, we had state, we had several levels of federal law enforcement. And what we were made aware of is that the patients, the things that we were removing from patients, shrapnel, and that could be anything from BBs to nails and all manner of things, were really evidence. So one of the key features of operating room practice is having a chain of custody for evidence. And it was very, very difficult to understand and figure out who actually should receive that. I mean, in normal times, if it was a bullet wound, for example, that bullet would go to a local law enforcement. But with so many levels there, it was very hard to establish who was actually responsible and who should receive those items. So we set up a pathology system to store everything and, record it in such a way that they were there and available. And once that was sorted out, we would take care of that. I think the last patient left the operating room, I want to say somewhere around 9 o'clock. And at that time, we were starting to think about, were we going to continue to see more patients, or, could we, send people home and start planning for tomorrow? We actually started to reach out. We wanted to reach out initially with our telephone tree that was well established and something we keep up to date. And as others have mentioned, telephones were not available. So we did rely on texting. and, sort of had a second string of staff on every level, sort of prepared and ready to come in should they need to. What we didn't initially realize is that this was not a single event. This was not a single day event. These patients actually came in for surgery, and, the initial surgery was really to stabilize them and take care of their wounds as a very initial stage, but many of those patients stayed for weeks and months afterward and required additional surgery and additional return trips to the operating room. So, the staff actually likened it, post-event, the staff actually likened it to working in a war zone. And I think what was especially difficult was that the patients were not, these were all vital, many of them athletes. And I think that was particularly difficult on the staff that were caring for them, because it could have been their brother, sister, mother, father.
Yeah.
And I think the other thing that we quickly realized is that we may have had, the patients that we had probably had family members with them who they didn't know the status of. I think in one situation, we actually had one husband and wife, and I believe we had the husband at Beth Israel Deaconess, and the wife had been taken to another facility. So that was especially difficult, but very challenging times. But, I really credit a lot of our response and our ability to care for those patients, the triaging of them and the arrival to the OR on the previous drilling. The staff had been involved, I had been involved, all of the surgical leadership had been involved in those drills, and it really contributed to a much smoother success rate than we might have expected otherwise.
So a challenging event for your hospital and your staff, obviously, but it sounds like the recurring theme here is that the city of Boston is a well-oiled machine in terms of providing mass casualty incident response. It sounds like you were fully staffed, and that your staff had done a lot of preparation ahead of time, a lot of planning, a lot of training. So just one quick question. You mentioned a challenge with instrumentation. Could you clarify that for us? Are you speaking about amputation kits?
Yes.
Is that what that is?
Yes. So essentially we have, operating rooms on the East Campus, and then we have a total component of operating rooms on the West Campus, which is our trauma ORs, and then the same thing on the East Campus. We do all of our total joint replacements. So many of the saws and drills that we use, certainly we have trauma equipment at the West Campus that we use on a regular basis, but all of our joint replacements are done on the East Campus. And so we have another whole department or whole division that has all saws and drills for those. But when we realized we were going to outstrip our resources in terms of the same kinds of surgeries that we were going to need to do, we brought equipment, saws, drills, and other equipment and instrumentation from our other operating room to the trauma operating room to be able to, be a backup. The other one thing that I forgot to mention is we actually had one patient too that had a very severe eye injury. And we did consider doing surgery for that patient at our trauma operating room. All of our eye equipment happens to be on the East Campus. So when we really thought about it, it made the most sense to have the care for that particular patient go to the East Campus, which is our other operating room. So I think that was where the patient could receive the best care, and I think that was still the right decision. I think that what was really difficult about it was that was one operating room with a small number of people that was sort of operating on an island, if you will. Again, a very limited number of people. On the West Campus, there were many, many, many people. On the East Campus, it was just that one operating room, and they, later described feeling, isolated in that. I mean, we did provide it was the right thing to do for the patient, but it was very difficult for that staff.
One last quick question, and it deals with the types of injuries. The backpacks were obviously placed on the ground. Is it fair to say that the majority of injuries were to lower extremities, or was there also a lot of penetrating trauma above the waist?
Much of what we saw was primarily lower extremities, but we did see a few others as well.
Interesting.
One staff member described a especially difficult realization that what they saw, and this brought things to a whole different level. In addition to removing shrapnel from wounds, they actually remove skin from wounds that couldn't possibly have been from that same patient.
Mm.
So we immediately recognized that there was another whole level that we hadn't initially considered at all. There were patients that had injuries that, you know, contained fragments from other patients, from other individuals. So, you know, again, another whole component around, you know, possible disease transmission and so forth. Really
A lot to deal with for sure, no doubt. Well, thank you all for your very compelling answers to our response phase questions. Our next 6 questions will deal with personal and organizational preparedness. We'll consider some of the lessons learned and maybe some best practices, and maybe hopefully discover a few techniques that we'd like to include among our own bag of tricks, among our own skill sets. I think we can all agree it's very challenging to adequately plan for an event like this. There's just no way on earth to exactly replicate the intensity of that day in a training environment. And I don't think there's any way to introduce perfect authenticity to an exercise environment. However, planning, training, exercising, it's all totally indispensable. So let's unpack this topic just a little bit with our second round of questions. And once again, we'll start with John from Boston EMS. John, based upon the events of that day, can you share with us 1 or 2 best practices for managing a casualty collection point at an MCI?
Yeah, where we were on Boylston Street was, we didn't have the option of going to a tent where they had, you know, physicians there and pre-staged ambulances. Our casualty collection point was actually the bomb site.
Right.
Some of the lessons learned, points to make, is that when you establish a triage and treatment area, make sure that the triage and treatment is actually done. EMS, we used a rapid assessment, rapid transport. With this amount of patients, that rapid transport is going to be delayed. So you need to keep reassessing, evaluating for changes. Make sure you have adequate resources in the treatment area. If you have 30 ambulances, only one or 2 EMTs in the treatment area, you're going to be delivering dead people. And I think a big part of the triage and treatment is keeping people focused in their roles. Individuals should have a clear understanding of what their role is, and they should stay in their lane. If they're in charge of loading, they should stick with loading. If they're in charge of triage, stick with triage. When people start confusing roles, things fall between the cracks.
Okay, well, thank you for that answer. And Dr. Dyer, the tactical response at the blast sites provided the foundation for so many positive outcomes in this case, but those positive outcomes rely as much upon the operational and strategic decision making that is needed. So that said, are there any types of training or exercise methods that might best prepare an EMS supervisor or manager to fill a leadership position at an incident like this? How can you get somebody ready to fill a leadership role?
Yeah, that's a really great question.
So I'm not sure if you're muted. So does Boston EMS have any particular training or exercise methods to train future leaders for worst case scenarios?
Yeah, we do. We have a lot of very kind of on the ground practical training. And also to remind everyone that a lot of times the first person there might not be someone who's already designated as a leadership role. But even when we do small MCIs, we train our people to be, you're the first one there, you're the one in charge. And that way, that kind of thought about taking control of a scene is actually generated from the bottom up rather than the top down.
Mm. So you have to emphasize with everyone, regardless of position, that they need to have a take charge sort of attitude, I guess, and be prepared to assume leadership roles. So it's probably a very good technique. So Erin, a question for you. As we learned that day, critical decisions are made based upon the timely gathering and accurate sharing of medical intelligence. Can you share with us one or two best practices for sort of optimizing the preparedness of the preparedness of those in information manager positions, and maybe the effectiveness of the information systems?
Sure. I think first, from the perspective of information sharing and information systems, is knowing your audience and the information that they value. I think that is critically important, and I think it's also important that the team you're working with knows that. And in doing so, bring in your audience, your partners and stakeholders who are the recipients of your information, and have them inform the process and the development of what information is going to be shared. I think on that note, as it relates to the timeliness of information, is be prepared to communicate and disseminate information with the best knowledge you have at hand, taking into consideration the unknowns of the situation. When it's the actual response to a crisis, there's always going to be a desire for more information, but ultimately you're going to have to make a decision to communicate information with the limited information that you have. I think secondarily to that is building in the redundancies that we've talked about in terms of our plans. We all have them, but plan for the crisis within the crisis and the failures that you can expect, because they're going to happen. It's just a matter of what it is.
Right. So redundancy equals resilience, I guess, right? And you also want to make sure that all your stakeholders are involved in the establishment of whatever information management architecture you're setting up. It's a real team effort, it sounds like. So thank you very much. Meg, back to you. There are not many events that can match the complexity and intensity of that day, but it seems by most accounts that the hospital command centers and the incident management teams performed about as well as anyone might expect. But even in the wake of success, the impetus to maybe refine incident management plans and response training programs might still exist. To that extent, or to what extent, if any, did you see the approach to HICS training or command center operations change after the bombing incident?
So, we definitely had many lessons learned. And we had a lot of reflections and things that we are doing differently now than we did before. I think one of the really important things to teach, when you talk about preparing leadership, is to really let them start to critically think about complexity. What is the scale and the scope of this to get your hands around it? You see it in national disasters, especially that breach multiple regions. How do you get your hands around it, right? So we talk about complexity a lot. We talk about, are there specialty patients? Are there burn patients, pediatric patients? Is there a security and safety aspect to this event? What is the time and the weather? So if you have to decon people in the middle of winter, it's very different than doing it in the middle of summer. Is there an intent to the event? Because that's going to add a whole other complex dimension. Barbara talked about, we were coordinating with 29 law enforcement agencies dealing with victims and the suspects. That gets really complex fast. And then also, I know they recognize this in 9/11, is understanding how you're going to get through that fog of war with the novelty of an event. How do you start to pick away at something that you may not have practiced before? So I think some of the lessons learned that we think about is that our emergency response plans have to be very agile and flexible, and a lot of critical thinking goes into them. You can't think that you're going to write a recipe card on how to respond to an event, because it's something as simple as a steam shutdown in New England looks very different in the summer than it does in the winter. So if you're always putting the same ingredients in, you're not always going to get the same outcome. So you have to have that critical thinking skill set. For me, as the head of emergency management for the system now, the most important thing I can do for anybody is to practice and train people so they start to develop some sort of pattern recognition. The more people see things, the easier it's going to be to walk into that event and kind of have in your mind, what are the steps that I need to take? How am I prioritizing what we're doing first, second, and third? I think then also nurturing an agile incident command team, so that you do get the innovative practices that you need. You know, people know how to kind of walk through the plan and the guidelines, what they're going to use, how they're going to change it, and what they're going to do with that. And they're able to transpose strategies to fit the needs of the event, not because it's in the plan as this. I think leadership in a high threat environment is something that everybody needs to think about, because the safety of your staff is so highly important, and you really have to be able to make kind of decisions that we would never normally make on a day-to-day basis very quickly and be able to pivot on that. And how to dig yourself out of the fog of war, to be honest with you, so you can kind of see and start to think about how you're going to approach the event. The last piece I'd like to say that, we think about and we've learned is how critical and important our community connectivity is. So we do a lot of drilling. Like I said, the last exercise I did while I was at BI was an active shooter at a college campus next door that generated 74 moulage patients in our hospital that day. I drilled deep into the hospital, and I want to drill to the point of failure. But also equally important is I bring in law enforcement, I bring in fire, I bring in EMS. We actually had the Joint Commission at the hospital looking at that drill that day. So bring in your partners, because you're never going to do this alone. So that community connectivity is very important. And then the training we do with our community partners. I know all of us in Boston had done multiple urban shield exercises before the Boston Marathon bombing that people that hold role in incident command, they were actually integrated into those drills. So the training and the drilling, and I know day to day, all of us hospitals are competing, but when it comes to disasters, we connect and we interlock like that, and we work together and go step through things together. And that's extraordinarily important. And the connections that we have and constantly our nurturing are really important. So our training really is surrounded by things we learned on the marathon bombing, but also things that we had in place before the marathon bombing.
So it sounds like a lot of premium is placed on that interagency training and preparation. And then within your own organization, it sounds like there's a real mentor protege concept that's going on to get people trained up. And then lastly, you mentioned agility for incident management teams and for your command center. And I think that can't be emphasized enough, because you never know what's going to be coming through the door, as we found out on the day of the bombing. So thank you for that great response. Dr. Gorelnik, even with so many severely injured victims, not a single patient died in your emergency department or in that of any hospital for that matter, but this can only be the result of your ED's commitment to detailed planning, rigorous training, and realistic exercising. So from your experience, can you share with us the ingredients for success when it comes to preparedness and high achievement in an emergency department?
Sure. I think, of course, we have to remember the 3 victims that died prior to on-site, but every one of the 270 patients that made it to hospitals, they lived. And I think, as each of the speakers have highlighted, the interdisciplinary efforts across the board, getting to know people, not meeting them for the first time during an actual event is critical, whether those are colleagues within a department or across departments or across hospitals was incredibly helpful. I think also the sort of the training and recognition of when we all are in a fight or flight stage, when there is stress, to be able to recognize when you're stressed and to take a breath and take a step back and sort of reframe the situation. we had practiced that quite a bit. You practice that as a routine, quite frankly, in the emergency department. If you have a sick patient coding in front of you, there's nothing better than training like that, one-on-one versus a mass casualty. So the idea that we've been through this on a micro level, and now this is more of a macro level, just taking each patient one by one and caring for them was incredibly helpful. And I think the last piece is just around understanding that the recovery starts when the bombs go off. In this case, again, we really, I think we invested a lot in the response piece and all the drills. And I think what we learned is there's a much larger arc on the recovery piece. So that was that we learned on the fly, and many of us have integrated in our plans, but there's a fair amount left to do around from the beginning, thinking through all of the different elements we need to help resilience within our community on the local level and the more global level. Whether that's having behavioral health experts with clinicians, with patients, with family members, clergy, social workers, and other disciplines to really help us navigate those first hours, days, weeks, and months, and longer term rehabilitation services and coordination around the community. So I think that was the other big piece where we did a little and learned a lot and have integrated into our plans a bit of recovery across the board.
Our very comprehensive approach and a lot of emphasis on training and preparation. So that would give you the ability to maintain your composure when you need to have it most in these challenging circumstances. Thank you, sir, for that very interesting answer. Very insightful. Okay, Barbara. One thing that I think sometimes people forget is that, and I think you mentioned it earlier, is that many of these patients needed multiple follow-on surgeries and very complicated prolonged care. Can you discuss with us the importance of a mass casualty service, the mass casualty service team that you mentioned, how it provides preparedness for these types of events? Tell us about what the lessons learned from your mass casualty service that was put in place.
So in addition to the preparedness, I think this is one of the real gems, if you will, that came out of, in terms of learning that came out of the marathon bombing event. As we said, the surgery finished the day of the bombings. The surgery finished about 9 o'clock at night. Many of those patients had, essentially either life-saving or limb-saving procedures and initially stabilization type procedures. The surgeons, that had been there quickly realized that they were going to need revisions, wound revisions, additional surgery. Some patients had initial shrapnel removed, but much was more deeply embedded and left for a later planned surgery, if you will. So one of our challenges was that we have this West Campus trauma operating room that runs a full schedule every single day, and surgeries for all levels of patients, spine surgeries, all manner of services were booked, weeks to months in advance. So how would we make time for patients, a group of patients that was going to need to come to the operating room on a regular basis for the next, several weeks to months? So several of the surgeons got together and worked with hospital and perioperative administration and set up special surgical time. So in other words, they had dedicated surgical time, excuse me, on the OR schedule so that if they needed to do a wound revision or additional surgery, they would actually have time and space available to do it. They also realized at the same time that these were not ordinary injuries. These patients experienced, trauma even beyond what you would see in an automobile accident, for example. So they also need other kinds of services, supportive services, social work around, work-life issues, pastoral care. So the mass casualty service actually pulled in many of those disciplines and engaged in rounding those, the pastoral care service, the social workers, all of the surgeons actually rounded on those patients on a daily basis and sometimes several times during the day over the coming weeks. I think what was really unique about the mass casualty service is not only did it take place while the patients were in the hospital, but they actually kind of saw a preview of what these patients were going to need on their return visits for follow-up care. So rather than have a patient come and set up an appointment with an orthopedic surgeon and do another one with a plastic surgeon and yet another with, social work, they actually created a clinic so patients could come and actually navigate all those appointments in the same sort of general space at the same time. So it took the burden off the patients of having to, create multiple appointments and make sure that they, were arranged in such a way that they could get them all done in one day. So that actually went on for literally months afterward to help meet the ongoing needs of those patients and help them heal. I mean, many of those patients, couldn't return to work, and they supported them on every single level. It was truly amazing and just really noteworthy.
So it sounds like the mass casualty service really brought a lot of cohesion to what would otherwise be a very complex and prolonged process for these patients. So that's a remarkable thing. So in our remaining few minutes, we don't have much time. I'd like to get a couple of questions in if our audience has any. And let me just tell our audience that if we don't have time to get all questions answered, you can email me directly at the conclusion of the session, and I will do my very best to track down an answer for you. So let's see if we have any questions, and we'll ask our audience to use the chat feature, and we will unmute you so you can directly speak with our panelists. Anyone? Bryce raising their hand? Well, I guess then the very good news is that you all gave such comprehensive, specific, and amazing answers to the story that perhaps there are no questions, but we'll give it a few more seconds just to see if we have any. We do have a little bit of feedback saying what an incredible and informative presentation this was from one very appreciative attendee. So if we have no further questions, I would like to just share this slide with everyone because we really should never, ever, ever forget the victims. And I would like to actually name them Crystal Campbell, rather, a 29-year-old restaurant manager from Medford, Massachusetts, and Lou Lindsay, a 23-year-old Chinese national from Boston University, a graduate student. And sadly, we have an 8-year-old victim whose name was Richard Martin, and he was from the Dorchester neighborhood of Boston. I did include Officer Sean Collier in this too, because several days later, of course, most people know he was murdered by the terrorists. And so I think it's very important to include him in this as well. And we do have a question that did just pop up. So the question is, aside from blood, were there any equipment issues that you would now identify? I guess, were there any shortages in equipment, perhaps at the scene or in the hospital? Anything that stands out?
I guess I would say, from the operating room.
Sorry, Barbara, I think you're breaking up. We can't hear you, or I can't hear you anyway. I think we're losing some audio here. Meg, can you hear me still?
I can hear you. Yeah. Can you hear me okay?
And I can hear you as well.
So I think, Barbara, you're coming in garbled for some reason, but I think she's speaking to probably is the OR. And I think we weren't the only hospital that had to go outside for more of like amputation kits, that kind of thing. but there was not an issue with blood. I remember during the response, the Red Cross coming in with coolers of blood. So we did not have an issue with the blood shortage. And I can't think of anything else as far as equipment and supplies that we were needed. And then Christine asked about how we deal with the mental health PFA issues. So, you know, this was I can answer for Beth Israel, and probably Eric and Barb can also touch on this, but, you know, to this day, we still send social work teams out every time the marathon comes around every year. You know, sometimes these emotions bubble up in people that were there that day. You know, we spent a long time, you know, I want to say that, you know, the day of the bombing, the FBI and ATF were in there interviewing any staff that had any interaction with these people. But we started social work teams immediately and created them for different units across the hospital that were integrally involved. I think a big takeaway for us was it's not just your clinicians that you have to really make sure that they're okay. We had housekeepers that were greatly impacted because they said they've never seen so much blood in their life when they went in to clean up the rooms. We didn't think of that. Another big issue for us was the nurses that took care of the 2 suspects, that they felt very isolated. They couldn't go home and talk about this with their husbands or their family members. They couldn't talk about it with their peers because they were literally separated from them. And they felt like the public would be angry at them for taking care of these people that had done such a horrific thing. So we brought in like the Israeli Trauma Coalition to help with that. And I think it wasn't until about a year later, a piece went in the paper about it and they got kudos from everybody. And I think that helped heal them. But it's an ongoing issue, you know, and also dealing with the mental health of the families and the patients. We had the Semper Fi organization across the city going into hospitals to meet with these people because they're young, they have amputations, and they have people that have been through the same thing. So that was also really important, but it's something that, you know, when Eric talks about the length of recovery, the mental health issues are one of those that really take a long time for people to start to heal from this type of an event.
I think it's very good that the mental health issue came up because obviously it plays a big part for the victims, but care providers themselves can also have a very long journey to recovery as well. And I think we always have to recognize that. And I think you mentioned that, Meg, so that's very important. So,
Kevin, if I can just quickly add on to Meg's point, I think one of the things to consider, and one of the things we managed to admit, was the overwhelming support of mental health and behavioral health resources. And how are you going to vet those? So we really relied on our federal partners to assist us through the federal public health service, the Department of HHS and the American Red Cross to validate and ensure that the resources that were coming in were appropriate and credentialed. And that was something that carried on for weeks and months following the bombings.
interesting. Yeah. Truly a collaborative effort with a lot of different stakeholders. Very important to have in place for sure. I'm also receiving a question about the sharing of this presentation. So I'm just going to say that the session was recorded and it is going to be placed on our website here at Stony Brook, our regional training center website. So I can share the link with everyone who participated, and you'll have an opportunity to go back and listen to it over again if there are particular subjects that you want to cue in on. So yes, it is recorded and it will be made widely available. So, okay, looks like we have one more question, and I think you can maybe see it in the chat, but if not, the development of your mass emergent communications and sending. Oh, I'm sorry, there we go. I didn't have it scrolled up all the way. What recommendations or best practices could you offer regarding the development of your mass emergency communications and sending consistent and informative messages to all staff. What systems do you currently use, and how do you include them in your drills? So we're looking for best practices regarding the development of mass emergency communications.
So I can speak briefly for Brigham and Mass General Brigham, our healthcare system. We use sort of a combination of two. We use Everbridge, which is a system that leverages both, cell, pager, landline, et cetera, and has a variety of different ways to interact via that. Our challenge is we haven't made this mandatory for all staff to sign in so they can get these alerts. The other piece we have for any critical staff members that are involved in different types of responses, we have a number of different page groups, whether that's our command and general staff and hospital incident command leadership sort of group, which is command and general staff and others, versus trauma alerts or other specific sort of alerts or pathologies that we need to team. So for example, an aortic dissection, a little different than a mass casualty incident, we have a multidisciplinary team and a page group that would page that group together. So we built a lot of different page groups, and those pagers, they can usually either use a hard pager, or those can be routed to individual cell phones. But those are sort of the two structures we've used: page groups plus Everbridge.
Okay. Very good to know, very informative. So regrettably, we have run out of time. So before we leave, though, I would like to announce that our partners out in Rochester are conducting the next in our webinar series, our August webinar, and it has to do with emerging infectious diseases, lessons from COVID-19, and that is going to occur on August 17th. So please look into registering in the LMS for that session. And with that said, I would like to thank everyone who attended, and most especially, I would like to thank our esteemed panelists. You're all very, very busy people, but you're also very knowledgeable, and there's a thirst for knowledge out there, and you've been very gracious to share your time and your insight. And I wish you all well. I thank you again, and keep doing the amazing work that you all do. And have a wonderful day. And thanks to everyone in the audience.